Hello again. Now we're ready for stomach disorders. Woohoo! So gastritis, that's the first thing that we'll talk about that is in your book. You all should know what nausea and vomiting is. Again, there are more blue definitions on page 1094, so take a look at those and throughout the chapter. All right, gastritis, acute versus chronic, erosive versus non-erosive. So gastritis is inflammation of the gastric mucosa or the stomach lining. So what caused it? What are the cellular changes? Or where are the lesions? And maybe it's erosive and maybe it's non-erosive, as the slide says there. So H. pylori is the most common cause of gastritis. And again, it's inflammation of the gastric mucosa after exposure to local irritants or other causes that can result in acute gastritis. Long-term NSAID use, however, can also cause gastritis. Other risk factors are, there it is again, alcohol, coffee, and caffeine. Stress and cigarette smoking are considered risk factors for developing acute gastritis as well. Drugs like steroids, drugs like aldosterone antagonists, and selective serotonin reuptake inhibitors, or SSRIs, can contribute to that inflammation and ulcers as well. So if you look at it directly, like through an EGD, chronic gastritis looks like a patchy inflammation of the mucosal lining. The walls of the mucosal walls and the mucosal lining of the stomach thin and wear away, basically atrophy, from chronic mucosal injury. The function of the parietal cells, if you remember those, the function of the parietal cells, which are the acid-secreting cells, decreases, and the source of intrinsic factor is lost. Those come from the chief cells. If you remember, intrinsic factor is critical for the absorption of vitamin B12. When body stores of B12 are eventually depleted, remember, pernicious anemia results. So again, the most common form of chronic gastritis is type B gastritis caused by H. pylori infection. Chronic gastritis is associated again with an increased risk for gastric or stomach cancer. Chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking have been linked to chronic gastritis. So on 1095, it tells you how to prevent gastritis. So there's a little box there that tells what to do. And of course, one of those things would be avoiding caffeine and NSAIDs and steroids and alcohol and stress. Symptoms of acute gastritis can be mild to severe. Chronic causes few symptoms unless there are ulcers involved. The EGD is a gold standard for diagnosing gastritis. So they can take biopsies for diagnostic purposes. They can look at the cells and tissue samples and check for H. pylori. So again, 1095, there's the prevention, how to prevent gastritis. And your book talks about assessment, and I want to point out the recognizing cues. There are the blue definitions there: dyspepsia, epigastric pain, hematemesis, which is vomiting bright red or coffee ground blood, like coffee ground emesis. And I want you to know the difference between melena, which is dark tarry sticky stool. So that melena comes out dark and tarry at the bottom because the blood has gone through the gastrointestinal tract. If somebody has hematochezia or maroon colored feces, that means that the blood didn't go through the GI tract, so it is a lower GI bleed. So there's a big difference. So sometimes gastric hemorrhage, like somebody is actually vomiting up bright red blood. So if that's a presenting symptom, it's a life-threatening emergency. So they need to get to the emergency room as soon as possible. So there, on this slide, it is telling you the difference basically between acute gastritis and chronic gastritis. And then again, an EGD is a gold standard for diagnosing gastritis. So acute gastritis is treated with supportive care. So if somebody has nausea, vomiting, has a like flu bug, quote unquote, we treat the symptoms and treat with supportive care, and we eliminate the causative factors. And maybe there are medications that block or buffer gastric acid secretions that we can use, or maybe things like Pepto-Bismol or Maalox or Tums or something like that can relieve the symptoms. Again, chronic gastritis may have caused breakdown in the stomach lining, so has destroyed the parietal cells and the chief cells, may require vitamin B12 because of loss of intrinsic factor, because we don't want to get pernicious anemia, and drug therapy to treat the H. pylori. So if you turn to page 1097, so this says gastritis and peptic ulcer disease drug therapy. So I'm going to go through some of these. So at the top, they start with antacids. And they have magnesium hydroxide and aluminum hydroxide. So magnesium hydroxide, Maalox basically, again, it's saying suspensions are more effective than chewable tablets. Just remember not to give other drugs within 1 to 2 hours of an antacid, because antacids interfere with the absorption of those drugs. People you give Maalox to or magnesium hydroxide hopefully don't have a history of chronic kidney disease. Hypermagnesemia may result, especially in patients with poorly functioning kidneys. If you remember from your OB, what is magnesium toxicity? What are you looking for? Why do you, if there's a pregnant woman who's on a mag drip, what do you assess that woman for? It's the same concept here, only this is a GI issue. So people can also become mag toxic on Maalox or milk of magnesia. So don't forget, it's the same electrolyte, it's just in a different form. So people can get hypermagnesemia. Something else that often occurs taking a lot of magnesium, like Mylanta, Maalox, those are magnesium products. We use those as antacids. But if we give people enough of those, it turns into basically milk of magnesia and causes diarrhea. So observe the patient for the side effect of diarrhea. Magnesium often causes diarrhea. Aluminum hydroxide, one example of that is Amphigel. Aluminum, on the other hand, of magnesium, aluminum causes constipation. So they are quite different there. H2 antagonists or H2 blockers, things like famotidine, which is Pepsid, it says give a single dose at bedtime for the treatment of heartburn and peptic ulcer disease. Bedtime administration suppresses nocturnal acid production. I think I mentioned that in a different, I think when we were talking about GERD, I mentioned that. Mucosal barrier fortifiers. Sucralfate or carafate, which is the trade name, is a, it protects the lining of the stomach. This is a big pink pill, and we usually put it, I would always dissolve it in water, and it makes kind of like a, what we call a slurry, and then we have the people drink it instead of taking it as a big pill, because those pills are really big. Another mucosal barrier, which you probably know already, is bismuth subsalicylate, which is Pepto-Bismol. I just want you to know that if people take Pepto-Bismol, it can cause their tongue to turn black, and it can also cause their it may cause their feces to be black as well. Going down, again, I'm on page 1097 with the drug therapy. Proton pump inhibitors, you've probably heard of those. Omeprazole is Prilosec. Lansoprazole is Prevacid. Rabeprazole is Acifex. Pantoprazole is Protonix. And esomeprazole is Nexium. So we give a lot of Protonix in the hospital. You'll probably see a lot of people on Protonix in the PCU. We give that because of it's a prophylactic way to prevent stress ulcers. So you might be seeing people get that PO or IV. You may see it in the ICU as well. Nexium. The next exemplar in your book is peptic ulcer disease, but there are types of ulcers caused by H. pylori infection. There are 3 types of peptic ulcers: duodenal ulcers, gastric ulcers, and stress ulcers. And I kind of just alluded to stress ulcers. So people who are high stress or have a lot of stress, such as hospitalized patients, are hypersecretory in that they have more gastric secretions. So they can easily get an ulcer. Duodenal ulcers occur more often than other types. Most of the time they're in the upper portion of the duodenum because they have an increased amount of acid coming from the stomach, and usually the duodenal secretions are basic because of all of the secretions from the pancreas and the gallbladder. So the one that they mention most in your book, though, is a peptic ulcer. A peptic ulcer disease results when the GI mucosal defenses become impaired and no longer protect the epithelium from the effects of acid and pepsin. So something interesting here is that urease is produced by H. pylori, and that urease breaks down urea into ammonia, and that neutralizes the acidity of the stomach. The H. pylori has that, it is a spiral, it's kind of a spiral bacterium, and it burrows into the mucosal layer of the stomach, and so the body's immune response can't respond to that infection. So it doesn't cause illness in most people, but it's a risk factor for peptic ulcers and gastric cancer. So H. pylori, we have to treat that with antibiotics to get rid of that infection. So again, many ulcers are caused by H. pylori. So here's just a schematic representation of how ulcers form. And I'll just let you look at that. So again, what are the types of ulcers? There's a stress ulcer, there's duodenal ulcers, and then there's gastric ulcers. So gastric ulcers develop they're usually in the antrum of the stomach. And that is by the acid secreting cells of the stomach generally. So here's a representation in the same pictures in your book on page 1098 of where most peptic ulcers occur. So gastric ulcers, duodenal ulcers, and it doesn't really delineate where stress ulcers can be formed. They can form anywhere. So again, why do people get peptic ulcers? Because of stress, for one thing, and because of H. pylori. That's a major cause of peptic ulcers. Too much acid. Complications of ulcers. The most common complications are hemorrhage, perforation. So basically that ulcer just eats through the entire mucosal lining, the muscular lining, and the serosal lining. So perforation, so it goes through the entire organ and perforates. Hemorrhage is the most serious complication, and it tends to occur most often in patients with gastric ulcers. So those in the stomach are the ones that are most likely to perforate and cause a hemorrhage. If that occurs, again, that is a medical emergency, so people need to go to the emergency room and not call their doctor. They need to just go to the emergency room. So if we don't treat H. pylori and the person has a second episode, if H. pylori isn't treated. They could again have another episode of that, so we don't want that to occur. So with massive bleeding, the patient is going to vomit bright red or coffee ground emesis, and so any kind of blood in emesis is called hematoemesis. The gastric acid digestion of blood results in that coffee ground appearance, and that's exactly what it looks like. So hematoemesis usually indicates that bleeding is at or above the duodenum or the jejunum, because any kind of blood that goes through the digestive tract is going to come out below in our feces as melena, or black tarry stool, because it's gone through the digestive tract. So in your book it says, minimal bleeding from ulcers manifests with occult blood in dark tarry stool melena. Melena may occur in patients with gastric ulcers, but is more common in those with duodenal ulcers. So your book also says perforation, since we're talking about perforation, occurs when the ulcer becomes so deep that the entire thickness of the stomach or duodenum is worn away. So just think about how painful that would be. And then, of course, the person could get a infection, and we talked just slightly about peritonitis in class. The abdomen becomes rigid and very tender, and the person is, they can get septic, etc. They have so much pain that they many times lay in a fetal position because of the pain. So again, they can get septic, and again, that is a sepsis, or septicemia is infection in the blood. They can become hypovolemic and get hypovolemic shock, and then their peristalsis no longer works, and so they develop a paralytic ileus. And so just don't forget that a peptic ulcer perforation is a medical and surgical emergency. So that, again, they need to go to the emergency room. If somebody has a lot of vomiting, they can become alkalotic and get metabolic alkalosis due to that vomiting of the acidic gastric fluid, and they can also become hypokalemic, resulting from that metabolic alkalosis. So again, why do we get peptic ulcers? H. pylori. NSAIDs is another culprit. Steroids and COX inhibitors. A family history is also a common occurrence if people have peptic ulcer disease. So peptic ulcer disease, incidence and prevalence. A lot of people in the United States have peptic ulcer disease. The mortality rate has declined over the past decades, but that's because we use more proton pump inhibitors and have early treatment for H. pylori. So again, I want you to remember peritonitis can be a complication of peptic ulcer disease, and erosion of the stomach and perforation of the stomach. Also, with diagnosing, or here's more assessment, another thing on assessment. So there's that word peritonitis again in red, rigid board-like abdomen with rebound tenderness, epigastric tenderness and pain, dyspepsia, So people will have a lot of pain. What is the impact on their lifestyle, their family, their occupation? Do they miss work? Can they not do what they always like to do just because of all this pain and this aggravation of having peptic ulcer disease? So just something to think about. Diagnostic assessment. So in your book under lab assessment, it tells you that there are 3 tests to detect H. pylori, either in the patient's blood, breath, or stool. There is something called the urea breath test, where people swallow a capsule or a liquid or some kind of pudding that contains urea with a carbon atom in it. And after a few minutes, the patient exhales, and if the carbon atom is found, the bacteria is present. So that's the urea breath test. The stool antigen test is our patients give us a stool sample, and we test it for H. pylori antigens. Another test is hemoglobin hematocrit. Patients who have bleeding from an ulcer may have a decreased hemoglobin hematocrit. So that is why a CBC can be done to help us diagnose peptic ulcer disease as well. For GI bleeding. So GI bleeding can be tested also using a nuclear medicine scan. That's at the very bottom of this slide here. So no special prep is required for that nuclear medicine scan, but the patient is injected with a technetium-99, which is a radioactive substance, and the GI system is scanned for the presence of bleeding after the patient waits for a while. So that's how they detect, that's a good way to detect GI bleeding besides for direct visualization through an esophagogastroduodenoscopy or EGD. I'm not going to go through, I think I already kind of went through this. So managing acute or persistent pain, again, we're going to do drug therapy. This is on page 1101, drug therapy. The primary purpose of drug therapy in the treatment of peptic ulcer disease are to provide pain relief, eliminate the infection of H. pylori, heal the ulcers, and prevent another bout of peptic ulcers from coming back. So this is something that you need to know. A common drug regimen for H. pylori infection is PPI triple therapy. Let's see if I have that on the next slide. Nope. Okay, so the triple therapy uses a PPI and 2 antibiotics. PPI and 2 antibiotics. So if you look on page 1098 again, where there's the picture of the common sites for peptic ulcers, there are antimicrobials on there. So any of these treat H. pylori infection. So antimicrobials to treat H. pylori infection: clarithromycin, amoxicillin, tetracycline, and metronidazole, which is Flagyl. So just take a look at those. But it's triple therapy. So PPI, 2 antibiotics. And those antibiotics, again, can be chosen from the list on page 1098. I want to point something out to you on page 1098 as well. It says in the drug therapy, right at the top, prostaglandin analogs, it says misoprostol. Do you know what misoprostol is or what it does? Maybe you learned about it in OB. I told you probably day one that I could link like stuff you learned in OB to GI things, and this is one of them right here. So prostaglandin analogs for GI, for gastritis and peptic ulcer disease, protect the gastric mucosa, and they actually decrease gastric acid secretion. Misoprostol for OB is it's called Cytotec, and it is not commonly used for GI stuff, but we can make a lady have an abortion by giving them misoprostol. So it specifically says there, do not administer to pregnant women. This drug can cause abortion, premature birth, or birth defects. So again, a lot of these things that you learn in nursing school overlap. Let's see where I was. So proton pump inhibitors are the drug class of choice for treating patients with acid-related disorders. So anything like any of those that are listed on page 1097, omeprazole, lansoprazole, rabeprazole, pantoprazole, and esomeprazole, which is Nexium, can all be used for that purpose. If you use a Nexium, again, assess for hepatic impairment. So this is not good on the liver. Nexium is not good for the liver. Usually we tell people, nursing students, that they cannot open capsules, like if they are enteric coated. If you look on page 1101 in the second column, it says omeprazole and lansoprazole may be dissolved in a sodium bicarb solution given through any feeding tube. Bicarbonate protects the dissolved omeprazole and lansoprazole granules in gastric acid. Therefore, the drugs are still absorbed correctly. These capsules can also be opened. The enteric-coated capsules can be put in apple juice or orange juice and given through a large bore feeding tube. So just so you know, some capsules can be opened to give by feeding tube. So this is what we want as a result. The person is not going to have active peptic ulcer disease or H. pylori anymore after treated. They're going to verbalize pain control or relief, and they're going to stick to their drug regimen and make lifestyle changes, decrease their stress, and those types of things so that they will live a pain-free life and get on with their life. And of course, the big one is that we don't want them to experience an upper GI bleed, or at least if they do have an upper GI bleed, they know where to go and not to call their physician first, but go to the ER and get that treated. So again, assessment of peptic ulcer disease. What's their history? What are the signs and symptoms? Assess their lab values. Again, how do we do that? We do that by their breath, by their blood, and by their stool. And then imaging and diagnostic assessments, we do that nuclear medicine scan, which can detect a GI bleed, but we can also do an EGD, which is a direct visualization. So again, just reiterating, Treatment interventions for peptic ulcer disease. PPI triple therapy is a PPI like Protonix, and that's just an example of one. It could be Nexium, it could be Prilosec, plus 2 antibiotics to get rid of the H. pylori. Antacids we discussed were magnesium and aluminum containing products, H2 receptor agonists such as Pepcid, mucosal barrier fortifiers such as Carafate and Pepto-Bismol, and PPIs like Protonix, and then antimicrobials, which are the antibiotics. Blood loss from peptic ulcer disease results in high morbidity and mortality. So again, these people, if they have any indication that they have a bleed of any type, they need to go to the emergency room, especially if they're vomiting blood. So non-surgical management, we kind of went through all this stuff already. Interventional radiology, like endoscopic therapies, you can read through those. I'm not going to go through all these. The interventional radiologic procedures start on 1103. I'm not going to go through all that. Drug therapy, again, is aggressive acid suppression to prevent rebleeding if somebody has a bleed. All right. So this is just put in there for your interest, and if I'd be in class, I'd be discussing all this, but you can just look at this and see what we use blood donations for. Gastric cancers, this starts on page 1104. Gastric cancer, most of those cancers that are in the stomach are called adenocarcinoma, and many times there are no symptoms, especially in the early stages. Gastric cancer can result because of gastritis, atrophic gastritis that is not treated. Gastric cancer spread through the gastric wall and into the lymph nodes. Somebody has really bad gastric cancer, like an advanced disease. I'm talking about the stomach muscle is actually invaded or even beyond. Lesions like that cannot be helped with surgery. The overall 5-year survival rate of adults with stomach cancer in the United States is poor because most patients have no symptoms until the disease is advanced. Again, H. pylori is the largest risk factor for gastric cancer because it carries the cytotoxin associated gene A. So patients with pernicious anemia, gastric polyps, chronic atrophic gastritis, and achlorohydria, which is absence of hydrochloric acid, are 2 to 3 times more likely to develop gastric cancer. So those are all causes of gastric cancer. So H. pylori, atrophic gastritis, eating pickled foods, nitrates, mentioned that earlier. And again, gastric cancer is spread or metastasizes directly by direct extension through the gastric wall into the surrounding lymphatic system. Please refer to key features in the box on 1105. So early gastric cancer, dyspepsia, abdominal discomfort, initially relieved by antacids. They feel full because they have a tumor that makes their stomach full. Epigastric pain, back pain, or retrosternal pain. And then there is advanced gastric cancer. One of the big things is anemia, and so that is why a CBC is useful to detect some of these and diagnose some of these problems. So if they do surgery on a gastric cancer patient, they're going to do a surgical resection by removing the tumor. So that's the best way that they can treat this. So total gastrectomy and partial gastrectomy are the usual procedures that they do for gastric cancer. So again, just reiterating, may be asymptomatic in early stages. But again, they may feel full. They may have abdominal discomfort that is relieved by antacids. So that is in the early stages. And then in the advanced disease, they would have anemia, which might be detected by a CBC. And then an EGD with a biopsy is used to diagnose gastric cancer. Again, we're talking about cancer, so there's that chemo and radiation again, and it's surgical resection. So gastrectomy is typically performed for a patient with a removable growth in the proximal or upper third of the stomach, so gastrectomy. So in this procedure, the surgeon removes the entire stomach along with the lymph nodes and the omentum. The surgeon sutures the esophagus to the duodenum. So in other words, whatever the person then swallows is going directly into the duodenum. There is no stomach, there is no breakdown of, there is no longer any hydrochloric acid, just goes right through to the duodenum. And so, how is that for the nutrition of the patient? So on page 1106, they show a total gastrectomy with anastomosis of the esophagus to the jejunum. So again, the stomach is basically bypassed, which could again lead to some nutritional problems. So on here I have NGT, nasogastric tube. Page 1106, column 2. If somebody has an NG tube that is clogged, again, the tube is not patent, so it can result in acute gastric dilation after surgery. So in other words, their stomach is going to get really big. This problem is characterized by epigastric pain and a feeling of fullness, hiccups, tachycardia, and hypotension. Notify the surgeon to obtain an order for irrigation or replacement of the NG tube to relieve the symptoms. So in other words, this is another instance where you don't want to be messing with an NG tube without calling the physician. You don't just want to go unclog a tube because it's there. Because these are, there's a lot of, again, sutures and anastomoses that can leak and burst, and you don't want to do that to your patient because it can just lead to peritonitis. So here again, they are talking after that about dumping syndrome. And again, this is in the second column on 1106. Dumping syndrome is a term that refers to a group of vasomotor symptoms that occur after eating in patients who have had a gastrectomy. Early manifestations of this syndrome, which typically occur within 30 minutes of eating. Vertigo, tachycardia, syncope, sweating, pallor, palpitations, and the desire to lie down. Late dumping syndrome occurs 90 minutes to 3 hours after eating, caused by a release of excessive amounts of insulin. So those are two totally different types of dumping syndrome, early and late. So I just wanted to point out that dumping syndrome. We talked about that before. Here's a picture of the gastrectomy again, showing that the esophagus is sewn right to the jejunum, so it bypasses the duodenum. And if you think about that, where does the pancreas dump its secretions for the digestive enzymes? Into the duodenum. So again, what are the nutritional implications of this type of surgery? It's a big deal. It's a big deal. So 1106, bottom of column 2. Several problems related to nutrition develop as a result of partial removal of the stomach, including deficiencies of vitamin B12, folic acid, and iron, impaired calcium metabolism, and reduced absorption of calcium and vitamin D. These problems are caused by a reduction of intrinsic factor. So I've mentioned that several times. And then again, the dumping syndrome. On page 1107, there's a diet for dumping syndrome. Make sure you are looking at what foods people shouldn't have and what people can have. So vegetables, cooked vegetables, potatoes, pork, veal, lamb, beef, eggs, poultry. So they can have those. And then there's foods to use with caution and foods that need to be excluded. So make sure you're looking at that. Page 1107. Again, with a gastrectomy, assess for the development of atrophic glossitis. This is in column 1. Secondary to vitamin B12 deficiency in atrophic glossitis, the tongue takes on a shiny, smooth, and beefy appearance. The patient may also have signs of anemia secondary to folic acid and iron deficiency. Monitor the complete blood count for signs of megaloblastic anemia and leukopenia, the white blood cell level. So just know that people who have had their stomachs removed or part of their stomach removed get nutritional problems. And when they get nutritional problems, their symptoms manifest as like this, a red beefy tongue, and they just don't look well. So that's called atrophic glossitis. Their tongue's real smooth, like they don't have taste buds on it, and then a real beefy red appearance. So those are people who have nutritional deficiencies. Dumping syndrome, again, we've talked about that a couple of times, but here are some symptoms again. And again, 107, diet for dumping syndrome. Make sure you are looking at that. And again, if you have any questions about anything that we have discussed on this PowerPoint or any other, make sure you contact me. I appreciate your patience. Thank you very much for your attention.